Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Seth Bilazarian, joined by my Senior Associate, Dr. Kenneth Adams, and he's going to take on a challenging topic today that I think is really important, and that's the topic about, generally speaking, about what kind of therapies are appropriate at end of life and decision-making around that. His specific title is Cardiac Device Therapy at End of Life, and I'm very interested to hear what he has to say. Dr. Adams.
Oh, thanks for the introduction. Let me tell you what stimulated my interest in this. I've had several patients over the years who have asked me about whether I could turn off their pacemaker, whether I could turn off shocks that they might get from the defibrillator. And also I've had patients who've been very sick and unfortunately suffering from a malignancy that was widespread, and they had a device and they want to make sure the device didn't keep them alive longer than they wanted to be alive. So I think it's a really challenging topic, and let me, before I go into the main part of the topic, let me just throw out three different scenarios that people can think about as I discuss this topic. So one is a 90-year-old patient of mine who has had a pacemaker for many years, but he didn't want to live anymore, and he was afraid that the pacemaker was going to keep him alive longer than he wanted to. He was otherwise pretty healthy, but every time he came to the office, we had a discussion as to whether I could turn off his pacemaker. The second example is a 60-year-old patient of mine who developed a metastatic cancer, and still was doing okay, but was worried that if he took a significant turn for the worse and he didn't want to remain alive, that the defibrillator and the pacemaker part of it were going to keep him alive longer. And the third example, which is the most recent one, was, again, another unfortunate story, a 70-year-old patient of mine who has a pacemaker in place and was now in hospice and wanted me to work with her to turn off the device. So those are the kind of things that stimulated my interest in, what do we do when we have these devices in patients and they may not want to have them in anymore?
Sure. Well, let me just, I want to make sure because I think I understand, but let me just frame the question. So one question is, what is in the best interest of the patient, just to fulfill what their desires are, but what's ethical for us to do, and what's legal for us to do? I guess those are the main questions.
Yeah, I hope to get to all those things. Those are great questions. And remind me if I stray from the topic a little bit. But as you know, and I know, and most of our audience knows, that managing these very ill patients in ICUs and CCUs has become more and more complex. We have so many different things we can do. We can put them on ventilators. We can put feeding tubes in. We can give antibiotics. We can put pacemakers on from the inside, or we can put a pacemaker internally. And we have also asked patients to make decisions about these kind of things even before they get sick. Like if you're very, very ill in the ICU and it looks like this limited chance of recovery, do you want us to do everything, or would you like us to take a more conservative approach? So those are the kind of questions we need to ask them. The other thing that stimulated my interest in this topic is some really high-profile legal cases. Now, these aren't necessarily cardiac cases, but I want to put them out there as a background to all the things that can occur and the way families can be torn apart by end-of-life decisions if they haven't been made ahead of time. Now, sometimes you don't even know that you should make them ahead of time. And for example, I think a lot of people remember the case about Terri Schiavo, a young woman who had a cardiac arrest at home when she was just 27. And she was resuscitated to a degree, but she never really recovered mentally. And there was a battle between her husband and her parents about whether life support measures should continue. And this went on, and then eventually, believe it or not, went up to the White House, where legislation was signed to keep her alive. And imagine how devastating that is for the family to have that kind of discussion. A second case was another young woman who was driving in Missouri, and her car landed in a ditch. She was found without any vital signs, but resuscitated. And she was in the hospital. She was, again, comatose, looked like a very poor chance of recovery. And her family wanted to remove the feeding tube that was keeping her alive. The hospital said no. The hospital said, no, we don't know what her wishes are, so we don't want to remove that. Ultimately, there was a court order to remove the feeding tube. And I think the most famous of all these cases, and I think everyone's going to remember this one, is Karen Ann Quinlan. who at 21 became unconscious after consuming alcohol and drugs. And she also, after her respiratory arrest, was in a vegetative state persistently. In other words, she was alive, but she couldn't do anything purposeful. There were battles between the family and the courts about what could be done. And as a result of her issue that was very well publicized, and this wasn't very long ago, it was in the 1970s, hospitals formed ethics committees, and people began to talk more about advanced directives to try to figure out what they can do when somebody is that ill. Let me go over a few terms. I mean, I know we've talked about pacemakers and ICDs in our previous shows, but pacemakers are devices put in to stimulate the heartbeat when the heart goes too slow. And some people are what we call pacemaker dependent, meaning without the pacemaker they won't have a heartbeat. And other patients they need the pacemaker, but they don't need it all the time, so they're not dependent. And then we have devices called ICDs, which are defibrillators. And we have different types. We have some that just function as a defibrillator that will shock the heart out of a bad rhythm. But we also have other devices that will actually help the heart beat stronger for patients who have a weak heart. So these are all the sort of the glossary of terms that we're going to be going through. Some of the material that I'm going to talk about has been endorsed by a lot of major medical societies. So there's what's called the Heart Rhythm Society, which is really the chief arbiter of pacemakers and devices and whether they should be changed or removed. But a lot of things I'm going to discuss have also been endorsed by the American Geriatric Society, Hospice, the American Heart Association, the European Heart Rhythm Association. So the goals of all this discussion are to make the doctors aware of what the patient's needs might be, highlighting the importance of discussing all this with the patient and the family, and trying to define a management scheme to deal with this. So you asked about some of the ethical issues. So it's clear that the patient has the right to refuse treatment. So if you talk with a patient and say, I really think you need this pacemaker, without it you may not have an adequate heartbeat, the patient actually has the right to say, no, I really don't want that. If they have a device in, it becomes a little bit trickier. If they say, I really don't want this device anymore, it's much different if they're pacemaker dependent, if they rely on that pacemaker for a heartbeat, or whether they just use it intermittently whenever the demand arises. There's also this, I know there was a show previously about advanced directives and healthcare proxies, and we've encouraged every patient to have at least a healthcare proxy, someone who can make decisions for you if you're incapacitated. And it turns out that those people who will call healthcare proxies or people who have power of attorney, that they have every right to make these decisions if the patient is incapacitated. And so how do we discuss this with the patient? So there's two concepts I wanted to mention. So one is informed consent, and almost the opposite of that is informed refusal. So when you discuss pacemakers and ICDs with patients, first of all, you have to make sure that they understand all the information. They have to understand what happens if I do and what happens if I don't. It's the same thing as when you're first putting the device in. Like, what happens if I get the pacemaker? What happens if I don't? If they have the device in and they want to terminate the device, what happens if I keep the device going? What happens if I terminate the device? So they've really got to be sure about that. So that's what we call the informed consent procedure. We assume they're going to consent because we think it's the right thing to do. On the other hand, they may, with all this information, refuse, and that's called informed refusal, which is certainly their right. Some of the ethical issues, we talk about euthanasia, which is letting people die with dignity. There's also the concept of assisted suicide, with Jack Kevorkian, and if a patient has a pacemaker or a defibrillator and wants that device shut off, that's much different than an assisted suicide. So in assisted suicide, you are doing something that will cause the patient's death. If a patient is very, very ill, that hospice patient I talked about, if that patient doesn't want to have the device anymore, doesn't want to have the chance of being defibrillated, and they say, I want this device out, or I want it shut off, what you're doing is you're terminating something that assists them, but you're not doing anything that will abruptly bring about their demise. So it's really very different. I don't want patients to get the idea that if you terminate a device or if you stop a device from working, that you're actually helping them die. You're not. You're taking away something that's helping another area of their body, but their underlying illness is the thing that's gonna hurt them in the long run. Now, sometimes patients will say, I'm not doing well. I know my time is limited, and I want my device out. Well, is that the right thing to do? Taking a device out is surgery. And those wires that we thread into the heart, they really almost become permanent. They're very hard to extract. If you try to tug on them and pull it out, you can really injure the heart, and you can really injure the patient. So if the patient says, I just don't want this device anymore, what are your options? So one option is you can reprogram the device. Any of our audience who has a device or has a family member with a device knows that we can bring them into the office and we can put what's called a programmer over the device. And we do what's called an interrogation, meaning what's the device set at, how's it working, and then we can reprogram it. So for example, if somebody has the example I would use for this is that 90-year-old patient of mine who just didn't want that pacemaker helping him anymore. So one of the things I discussed with him was, I feel very funny taking away your pacemaker, but maybe we can reprogram it so it's not giving you so much help. So we could say, okay, instead of having a pacemaker rate of 60, I'm going to program that pacemaker rate down to 40. So anytime your heart rate goes below 40, the pacemaker will kick in. That means you won't use it so much. And that might be a nice compromise for what he wanted. Keep in mind, too, that if a patient says, I want this device out, and you say, okay, let's do a surgical procedure to get it out, there's all kinds of risks with surgery. So I would say to try to do it an easier way and with the reprogramming. You and I put in pacemakers. We have another doctor in our group who puts in pacemakers. Is it right for us to refuse a patient's wish to take out a device? And I think legally it is our right to refuse because we don't have to commit a patient to surgery. I think, did you ask also about religious principles and how that might play in?
I didn't, but I'm interested.
Okay. I thought you had said ethics and religion, but it's very interesting because depending on the patient's religion, they may have different views about how they want to be treated at end of life. I don't want to get into everybody's different religious views, but some patients will say, it's God's will if I'm going to live or die, and whether I have a defibrillator or not, it's not going to make any difference. Other patients will say, my belief is that when it's my time to go, it's my time to go, and I don't want this device prolonging my life. So it has to be consistent with the patient's religious principles, and sometimes we might even ask a religious leader to come in and talk with the patient. We might have a clergy member come in and talk with the patient if the patient's hospitalized about the pros and cons of changing a device. To my recollection, this hasn't happened, but we might even have a religious leader talk with the doctor about, what are your views on this? Are they compatible with the patient's views? Are you comfortable turning off a pacemaker or a defibrillator? I think from a medical community standpoint, if the patient is dependent on a pacemaker, it's very difficult for a doctor to want to turn that pacemaker off, because when you turn that pacemaker off, the patient has no heartbeat. On the other hand, if they have a defibrillator, and as we know, and I want to explain to the audience, the defibrillators also function as pacemakers. So if you have a defibrillator in place, and you say, you know what, I'm okay that the defibrillator will occasionally give me a good heartbeat if my heart goes too slow, but I don't want it to shock me. Well, we have the option, if the patient agrees and we agree and the family agrees, we have the option to be able to turn off what we call the therapy, so that the pacemaker won't shock the patient. So that would be something that could be done. In fact, that's what I did with that one patient, that one scenario of the 70-year-old patient who had a bad cancer that was The patient only had 6 or 12 months to live based on predictions. And we decided to leave the pacemaker part of the defibrillator on, but turn off the defibrillator part. And I think the family, the patient, and I were all comfortable with that decision. We had talked about that a lot. There was an interesting study that was done where they polled 5,000 people. It was a group of doctors, legal professionals, and patients who had devices. The doctors and lawyers did not have devices, but the patients did. But 5,000 of them were polled. And it turned out that the doctors understood very well if the patient was dependent on a pacemaker, that could be very bad to just turn that off. But they didn't have as big a problem if the patient wasn't pacemaker dependent. The doctors also didn't have a difficult time turning off the defibrillator aspects of a device if the patient understood what that meant. On the other hand, a lot of the lawyers and patients who took that same survey said, we're just not sure if that's in the best interest of the patient. I think that, the doctors understand that too, but they felt at that time it was what the patient wanted, and the patient was very clear about it. Let me talk a little bit more about the idea that if a patient says, I just don't want this device doing this anymore. Are there any other ways that we could approach this problem? My device has shocked me every month for the past 6 months, and I just don't want to deal with that anymore. Well, there's other things that we could do. Sometimes when patients get defibrillators, they are not on medication. So if somebody is toward end of life and says, the defibrillator has gone off, I'm not well, I just want it, I want this to stop, you could potentially put them on some medication that may reduce their chance of having a rhythm disturbance that's going to make the device go off. The other thing you could potentially do is you could refer that patient to a rhythm specialist. And the rhythm specialist could help them decide if there's any area of the heart that could be ablated. In other words, could you introduce some radio frequency waves, some cold therapy, something that will interrupt the electrical circuit. So you haven't had to take out the device. You have had to put them through a procedure, but it's been a nice compromise. Like you're getting problems, you're getting shocked. We don't want that to happen anymore. It's disturbing the quality of life toward life's end. Let's do this ablation. A couple of things that we need to do as medical professionals is that we need to make sure that we document that the patient has requested this. I mean, this is obviously a very, very serious decision. We're talking about things that occur toward end of life. We want to make sure the family is good with it, that the patient is good with it, that the doctor is good with it. So we have to really make it clear that we've had the discussion. We have to make sure that the patient or whoever is making the decision for the patient clearly understands what's going to happen. Now, if a patient is dependent on their pacemaker and the pacemaker is turned off, they're not going to have a heartbeat. They have to be absolutely clear about that. Now, does the doctor have to comply with that decision? So if you or I have a patient who is dependent on the pacemaker and wants that out of there, and say, I just don't want this helping me anymore, I don't know how you feel about it, but personally, I have a really difficult time turning off a pacemaker of a patient who is totally dependent on it. So I might say to the patient, I'm not comfortable with that. It's really going to hurt you to do that. I'm happy to help you in other ways. I'm here to support you in whatever decision process you go through. But I think we'll probably need to find another doctor who might be willing to do that for you. The other thing I just wanted to emphasize is in these defibrillators that we put in, there is a distinction between the pacemaker aspect and the defibrillator aspect. So we can turn off the defibrillator aspect, but keep it as a pacemaker if the patient needs that. I just wanted to give you a little bit of a summary from that study that was done, and that was done through the Mayo Clinic when they polled a total of 5,000 people. What they actually did was they gave them 5 case scenarios and asked them to judge how they felt about that. So it turned out that the doctors involved in that survey more often than not felt that it was probably okay to turn off the therapies from a defibrillator. They weren't so comfortable with turning off the therapies from a pacemaker because more often than not the patient really needed that pacemaker to sustain life. Interesting from a legal point of view, the lawyers said that if it's okay to turn off a defibrillator, we'll just lump all the devices together. Defibrillators, pacemakers, all the same thing. You turn off one, you turn off the other, it's all the same. That might reflect just a legal opinion, or it might reflect perhaps a little bit of lack of understanding of what the devices are all about. The patients were really all over the map on this in this survey. Sometimes they felt it wasn't the right thing to do. Sometimes they felt it was the right thing to do. So no clear consensus from a patient standpoint. So I think overall it's a very, very difficult decision to make. And one thing that might actually be helpful is, and I think I'm going to start to do this more often, is when I have a patient in the office or in the hospital who needs a defibrillator or a pacemaker, I think more often now I'm going to have this entire discussion with them beforehand. Usually you have a discussion about why they need the device and what will happen if they don't get the device. And we talk about the risks of the surgery, of putting the device in. But we often don't talk about what happens if you want to reverse this decision in the future. So I think it would be worth the time to talk with the patient and say, if in the future you decided that you didn't want this anymore, here are our options. We could reprogram it. You might be eligible for another procedure. We could deactivate part of the device. We could reprogram the device. We could perhaps start you on some new medications that might take the place of some of the functions of the device. So it might be a good discussion to have beforehand. The other discussion I think would be good, not just from a cardiac standpoint, but from a standpoint of all of our patients, is to ask them, do you have an advance directive? Do you have a healthcare proxy? Do you have a power of attorney? Do you have someone that can make decisions for you, someone that you trust to make decisions for you, if that's necessary at some point in your life? And I think a lot of medical groups and a lot of hospitals are leaning toward trying to get that discussion underway before it has to be done.
Well, that's a very complicated topic, and I thank you for tackling it. I think that was brave to tackle it. I guess my comment or question I will ask you, though, is something that I struggle with. On the one hand, I think that the whole concept of advance directives, meaning making decisions or at least talking with a loved one or your own physician about what you're willing to have done in the future, is wise. And it's being promoted as a very important thing in our national health care reform strategies.
Absolutely.
And I think that makes sense at some level. But as a practicing cardiologist, I see a lot of problems with it. And very simply, and I'm interested now that you've been thinking about this, what do you think? Because even if you were to ask this question of yourself, I mean, not to disclose your own, but
right.
In the future, I would want this or I would want that, but we don't know because in a few years, of course, we may have some new disease process, our life circumstance may be different, our family member situation may be different, we may be widowed or some different kinds of situation. So I have dealt now several times, this is my real circumstances, would be in my role in taking care of patients with heart attacks. I rush to the hospital, and someone will have an advance directive that says they don't want anything done. They have what's called a DNR in place.
Right.
But they're having severe chest pain with the elephant sitting on their chest. And I say, well, I can't do this procedure if that's your decision. And they say, well, I want to change it. And that's okay, but it's a concern that I have because I think people then think that then they didn't really have a good advance directive. And one of the things that concerns me about the healthcare reform is that they're saying that they may actually punish doctors when patients change their mind, as if we manipulated them to change their mind. So I'm interested in your comments on that, but what do you think?
Those are great questions. The first one about whether you should be doing something for a patient who has a do not resuscitate order. This comes up at the hospital all the time when someone has that order, but they come in with an acute illness and they might need surgery. So a lot of times that do not resuscitate order will be suspended to allow the surgery to be done. And I think the same thing could be said for the patient who comes in with the heart attack. They always have the right to refuse and say, no, I don't want to have anything.
I have no objection to that.
Yeah.
Just want to be clear. If they reject, as you said, I find that to be very easy. I mean, I want to counsel them and make sure they understand the issue, but I have no issue with that. It's more this issue about the advanced director.
Yeah. The other, I think it's a very interesting topic. You know, it also depends on what side of the political spectrum you might be on. But there was that talk about the death panels. Like, you know, the doctors were urged to talk with patients about what their wishes are in terms of advanced directives. Now, that doesn't mean that they have to pick one. It just means you have to have the discussion, which I actually think in my experience, particularly when I have an older or sicker patient, they like the idea that you've actually brought up the topic because it's a very difficult topic to discuss. So you bring up the topic because have you thought about this? Have you thought about, you know, whether you have a healthcare proxy, whether you have a power of attorney? And I think that in the healthcare plan, whether you're for or against it really doesn't matter. But I think in the healthcare plan, I think the idea was to just talk about it, at least have that discussion. And in fact, you know, in our medical group, one of the things that our internists are measured on is whether they have a discussion with the patient who needs that discussion. So I think it's good to have the discussion. It doesn't mean you have to have an answer to the discussion, but you can at least bring it up.
All right. Well, that was a tour de force of discussion about issues around end of life. Not a pleasant topic for anyone to discuss, but a necessary topic because as much as medicine has advanced, our lives will all end. And trying to do a good job, taking the best care with comfort and with dignity at the end of life is something that I know we're committed to. But doing that well and to honor patients' ethical, religious, personal preferences can be very difficult because they can be really ranging. So Dr. Adams did a fantastic job breaching this subject, beginning to have a conversation, and I think his message that all patients should have this conversation with their doctors, either specialists or primary care doctors, and certainly the minimum things that he suggested, healthcare proxy and having someone that basic knowledge of someone that they know and trust, having a knowledge of what they would and would not be willing to have at end of life can be very helpful for us. So I thank Dr. Adams, and I will close this session of Matters of the Heart. I'm Seth Bilazarian. Thank you. Until next time.